last but definitely not least, I'm very happy to introduce Dr. Judy Gichoya. If you want to go ahead and share your slides now, Dr. Gichoya, you can. She is an assistant professor at Emory University School of Medicine in Georgia in the Department of Radiology and Imaging Sciences. She's a multidisciplinary researcher trained as both an informatician and a clinically active radiologist. She also works with NIH on the Open Data Science Platform, or ODSP, component of the DSI Africa Initiative to harness data science for health in Africa. Her career focuses on validating machine learning models for health in real clinical settings, exploring explainability, fairness, and a specific focus on how algorithms fail. She's worked on the curation of data sets for the Society for Imaging Informatics in the Medicine Hackathon and Machine Learning Committee. And today she'll be talking on bias in medical AI imaging, a data-centric approach. So thank you very much, Dr. Gichoya, for joining us today, and I'll hand it over to you now. Thanks.
Thank you. Thank you so much for the invitation. And also, I mean, very good talks. I was busy taking notes too. So this is a great symposium. I can't wait to catch up with some of the parts that I missed. So I'm just going straight into it. These are my disclosures, nothing that's going to affect the quality of this talk. And, you know, I sort of decided to narrow down on some of the work that we've looked at, because the data in medical imaging is really our images, and we have reports, and for a 20-minute talk, I think that may be a little more difficult to try and achieve. And so I'm going to be talking a lot about reading race paper, how AI recognizes patients' racial identity in medical images. And I think that's going to be relevant even from the previous speakers about some of this phenomenon we're seeing from either lung function testing, which we also correlate with a lot of imaging, and also as we start to even look at, social deprivation index and other population metrics that tell us where these patients come from. And so I'm not going to spend too much time on the common language, because it was actually described just even in the last talk, and what we refer to when we're reporting, race, ethnicity, and specifically for this talk, we defined it as just the social and legal construct, how you see yourself and how other people see you. And usually I find myself that I have to justify like what's in a name or label, and I'm an interventional radiologist. So unfortunately, we do get involved with moms when they're delivering. It's always not a very exciting time for some people because postpartum hemorrhage is actually a leading killer of Black women. And if you look at this data for severe maternal morbidity from the New York area, it doesn't matter on your federal poverty level. It turns out that even if you're the richest, just by being Black, and they've corrected it for education level, all these other factors, just by being Black, your chances of death in hospital when you're delivering are very, very high. And so we know that there are other things around, like, for example, pain is another example where we know there's quite a lot of disparities. I do procedures, and even anecdotally, you may realize that sometimes your Black patients may not get the correct, like adequate pain control, because there's the perception that Black people don't feel as much pain. And so quite a lot of work to be done there. And then on a bigger scale, not just in radiology, we see bias in ophthalmology and dermatology, and even in sort of just the clinical medicine. For example, this work done by Ziad, which is dissecting an algorithm that is being used to refer who are the most sick patients. And you can imagine, if let's say you've said, these are the patients that I've identified from a pulmonary function test, and these are the ones I'm going to send more resources for, and you're already biased in your initial decision on who's represented in that population, then you can easily propagate the bias. And I encourage you, if you've not read this paper, to spend time looking at it. I think it was fantastic work. And here they said, we don't even include the race of the patient, but when they look at the results, they see that Black patients are referred for additional care when they're much more sicker and in later stages of disease. And the reason is because they were using health costs. And yet, if you had sort of understood the health economics, you'd know that the Black patients usually incur more emergency room costs more than primary care costs. So the metric that you use even to tune or what you're going to target for your model is super important in terms of thinking about outcomes for this patient. And so why did we do this study? And this is something that I got asked a lot. why would you even ever look that the images have race information, And it turns out it was really a happy accident. We were looking at a paper just as a special issue, and we're looking at this work that had been done before to exclusion, which looks at 14 labels of chest X-ray and tries to figure out using true positive rate, which is a metric for bias measurements in computer vision for when you're looking at images, and we're just looking at how it would vary. And really, the ranges here usually are from, minus 0.8 to 1.2 is it's thought to be the band that's appropriate. But when you start to go lower, for example, here, cardiomegaly, then the white patients are less favored, for this subgroup. And we know, this group had already done this work. And, ultimately they say that, if you're Hispanic or Black, if you're on Medicaid, which is the insurance that, people who have low income are offered, then these models do not seem to work very well for you. And so this group also expanded their work and looking at just normal imaging, where there's no finding, a normal X-ray, and starting to see, how does it perform across groups? And they bring this new intersection too of around, for example, I'm a Black woman. And so if the model is not working well for women and it's also not working well for Blacks, you have this double burden of, sort of unfairness from a model. And they still found the same, Hispanics, Blacks, Medicaid, younger patients, but you have to be careful about the data set for chest X-rays, because most patients, when you're less than 18 years, you get imaged in a pediatric hospital. And we know that the public data sets do not really include that cohort. So you have to be very cautious about how you interpret that. But they, again, showed that this intersection, again, like Black female, Black, Hispanic, and, Black male, maybe even in a different category, that shows that there's this rate of underdiagnosis. And so here in Emory, which I think the people in Michigan would also appreciate, we have a big Black population. And, we said, well, we could repeat this experiment, and we were very sure that once you just show the model that a more diverse data set, these problems are going to be resolved. I'm just showing here the sort of three big public data sets. You're either using the MIMIC data set from Beth Israel, the Checks Expert data set from Stanford, or the NIH data set, but the NIH data set lacks the race information. And so, when we came here and we pulled our own data, you can see we almost have an equal population of Blacks and whites. And we said, we found the solution. We just need to show these models, more diverse data, and voila. It turns out that we were wrong, that we observed this. If I can convince you that this is a higher peak compared to this one, we found out that, yeah, maybe for cardiomegaly, you'd see that the amplitude of the peak went down, but the pattern persisted. And so this was really baffling. And when we started investigating why, we found out that it's because these models start to learn these underlying features, even on medical imaging. It's not just because, which is really extremely concerning as we start to even build these models that merge clinical information and medical images. For example, in the case of breast cancer, where you can look at the mammogram, but you can also look at the demographics and other clinical information. And so we then refined our study to look at three things: to first really quantify, was this real? Were we making a mistake? Probably we are, but and how did it work across multiple imaging modalities, and what could be causing this finding, and what were the confounding anatomic and phenotypic population features. And so we collected more data sets. We had the public ones. We were able to use our friends to get some race labels because those are overall missing. So we have very varied amount of race information from 6% Blacks to 44% Blacks. You can see these are chest X-ray data sets. These are CT chest data set, a digital hand atlas data set, a breast imaging mammographic data set, and a cervical spine data set. And then we set out, let's put in all the models that we could think about, and let's train these models and see what we find. And it turns out that the models perform very well. So I'm talking about more of deep learning models, ResNet, that type of architectures, DenseNet, and EfficientNet, and with AUCs of like above 94%. And this was very baffling. And without even training the model again, when we took it to a new institution, we've had several institutions try this, is that the model performed well. This is what, when you're building algorithms, you want in your life, that you train a model from Emory, send it to Michigan, and it works great. And that's like amazing. And so this was even more concerning. So then we said, you know what, maybe, so it's not the model itself, so we can't say that it's maybe ResNet only. And maybe we said, well, maybe it's something about the chest, how it's interacting with the images. So we looked at, the hand radiographs, the mammograms, and the cervical spine. And the mammograms, true, they are probably the least performing here in the 78%, but we see quite very high performance. Now, we do have 6 radiologists in our group, and none of us could perform beyond random, which would be around 50% in terms of identifying if this is a Black, white, Asian patient. And so we found that the performance was persistent across all groups, across multiple architectures. And saliency maps are really commonly used in medicine and radiology to tell us where the model is looking. These were haphazard. We spend a lot of time trying to audit them when they are normal disease, abnormal disease, and even ended up working on this explanation, which are looking at the latent encoding space and trying to see, when you stack all the images, what the difference is, and maybe getting a sense that it could be something about the shoulders, but still we know that we haven't, unfortunately, really found out what these models are looking at in terms of this imaging and being able to tell you where the race of the patient is. The same thing with the breast mammograms and the cervical imaging. Now, our initial hypothesis was that, that it may be something that Black skin interacts with the X-ray. And so what if we brought non-radiation type of imaging, for example, MRI or ultrasound? And so this group worked on doing this experiment using 2 brain MRI studies with as good performance above 95% for 0.95 AUCs for predicting race in, you can see that this is a UK data bank population. So that theory went out of the room. And so then we started to figure out, well, maybe these models are looking at, maybe the Black patients are bigger bodied, or we know that breast density changes across races. And sometimes maybe the Black patients just have, cardiac disease, and this is what they're looking at. And unfortunately, we were unable to ever find out that any correlates for BMI or breast density or age. And even when we combine them all together, we still have, it's not slightly more than random performance, around 0.64, but it's definitely doesn't account for the 0.94s that we see. And when we look at the disease distribution and just say, tell me the race just based on the label, it's still in the 0.6%, 0.61. And we start to pluck out some features. Now, the bone density experiments do need a little more work just to do the image manipulation, but that didn't really make a difference. And we also didn't notice any differences. For example, could you maybe predict better for 40-year-olds versus 50-year-olds versus 60-year-olds, or impact of patient sex. And so we then started to change the images, add noise, make them blurry. And in this case, this is our test set where we were sort of blocking where the model is looking at the most. And for this, we found a drop when we added noisy and blurred images. But like I mentioned, the radiologist's performance is around 0.5, and so it still doesn't explain the high performance, but it's better than the radiologist. And so this means that there is some race signal persistent in these images. And when we block where the model was looking at the most, we still see a slight drop in performance, but we see that even in other parts of the image that they may not be contributing the most to the model prediction, that they still have high AUCs. We started segmenting the lungs into the soft tissues and the lung tissues, and seeing how would that perform. And we see lower performance when you just look at the lungs. So it could be something still around the composition, maybe not just how we look, but what makes up the soft tissues, because we see much more performance, but still the performance in the lung is much better than random. And then we started to do this experiment where we would break the chest X-ray into components and then block each component, or just look at that component for prediction. And when we look at that component for prediction, we find 0.91 as the percentage. So for example, when you use C using one patch, but when we block and then use the prediction, we see the most significant drop when we look at this area above the stomach, which has a performance of 0.6. And I mentioned no difference between age or gender. This is probably the most concerning now. Now, when you have an algorithm, let's say a dermatology algorithm, and it's not performing well, then you could show me all your cases and I could say, those cases seem to be all on dark colored skin. But we applied these low and high pass filters that allow us to look at the, the gross things and the fine contours, at every end of the spectrum. So this is a chest X-ray after applying a high pass filter at, 100, a centroid of 100. And you can see this is barely perceptible as a chest X-ray. But in this X-ray, you still have a performance of, close to 0.85 to tell you what the race of the patient is. I mean, what are the models looking at when they look at something like this that we just call grayscale? And when we change the resolution, we start to come down, for example, this pixelated image here there that you couldn't even really tell was an image. At 4x4, you still have the performance of better than radiologists. It's true, it's not 0.9, but you can see even up to 40x40, this is when you are still getting this type of performance. We try to make sure that there's some sanity check. What if we shuffle the labels and we start to find now this more random expected performance? And we look at the equipment, maybe Black patients, and that could happen. For example, if you're big bodied, you may be scanned only on one scanner. Maybe if the clinic is close to one scanner, those things that you as a data scientist have to think about as you walk around could be affecting our prediction, but we don't really see much of a difference, even when we filter on one image, one scanner, at that level. And we find quite a difference in where patients are scanned. For example, this is a mammogram study. And, we also look at, this is 2 mammogram studies that are acquired across different equipment, and we don't see a difference in the performance. And again, this is just sort of like the location of the hospital. This is a more older population. This is a more academic institutions, so seeing a mix of patients, and this is more of a cancer population, and we still see a good performance sustained across. And so again, what about the pixels, right? These images, and we know that we've been changing the pixels. In radiology, you can use these organs to tell you whether this is normal, air, fat, soft tissue. These are some pictures examples. Usually looks much prettier on CT scans, and we don't find that as a contribution, although we've subsequently analyzed this in a different way that shows us that it still is not explaining why these models are able to pick up the patient's race. Then this group in Stanford had done something interesting on their data set where they had curated photos, right? So you have the digital image, which is what we were working with, but then they started to do this experiment as a way to show, for example, like home in Kenya, where I come from, what if you took a picture of the image, does the quality change? And so they had processed these images on iPhone and Nokia. Around 6,000 images were available to us, and we were going to sort of predict. So this is the same image. You can see this is after cell phone manipulation. This is the original image. And does that image still have race information? Yes, even if it's a little lower. So this is even, again, was very against our melanin hypothesis, but also like, how do you still persist this information across a picture of a picture? And so we found that we have superhuman performance for race detection on imaging, multiple modalities beyond chest X-rays. And this mechanism, unfortunately, this is close to 18 months of doing this work. We cannot figure out why. And what we would think would be obvious clinical confounders and anatomical explanations were not helpful for our case. And we still need to explore this phenomenon, especially as we start to embed it in the context. And I'll show you some of the things that are coming down the pipeline and also understand what this means for policy and FDA regulation. And so this is some work done again by this team by Emma and Ziad, who start to look at knee radiographs and osteoarthritis. I mentioned that pain is a big disparity for, especially for low-income earners, low education, and Blacks. And they developed the score that is usually used to grade osteoarthritis was trained many, many years ago, predominantly in a white population. It's called the Kellgren-Lawrence score. And they train an algorithm to generate this new score and find that the algorithmic severity, they also don't just use the imaging, they use the patient's reported pain, because you know that there's actually a discrepancy in that. And they find that when they use this algorithmic prediction score, which considers the pain factors from the patient, that they can mitigate and reduce the gap, you know, by almost 5 times based on race, 2 times on income, and 3.6 times on education. And, you know, it's not just doing this work, it's to see why it matters. And one of them is eligibility for surgery. And we find that when they use this algorithmic prediction score, it, you know, improves the amount of people who become eligible for surgery. And so, but when we start to unpack this and merge it to our work, we were collaborating with them and creating an MSK dataset here at Emory, is that we find that the model actually learns race. So now we don't know, is it because that the model narrows the gap between Blacks and other races because it's learning the race better? And it's not bad if it's using it well, but we know that these AI models are black boxes, and if they have confounders that we cannot really determine, then we will be, when I take it back to my home village and, you know, we have a heterogeneous variation of the race, then they're not going to work as well. And so this is an open area of research. And we have tried to do the same again with this Mirai model that also, again, just looks at the breast and tells you, you know, in 5 years, this is the risk of breast cancer, again, performing much better than the Tara-Kruzik model, which is predominantly very poorly performing for Blacks. Well, my last point here is to also remind that this coding that we still see for race, even if it baffles us and we need to figure out why it matters, we don't need to remove it, we just need to understand why it matters, is this idea of that missing codes, missing patient codes like ICD-9 or ICD-10 codes is actually an health equity issue. And we know this is some work that we had done looking at value-based care, looking at hierarchical codes. We know that they're overall incomplete, but it turns out that you can actually train your AI, and just looking at the chest X-ray, it's going to generate a problem list for you. So this is looking at chest. You can see these are much better, ablation studies to show where the model is looking at. This is congestive heart failure, atrial fibrillation. You can see with obesity, it's looking more towards also the soft tissues, and you can see vascular disease, it's looking at the aortic area, and diabetes also in the soft tissues and around the aortic area. And it turns out when we looked at these patients who did not speak English, and if you are a physician and you know you have to use those cards that you have to translate someone, Swahili to, you're not going to spend all the time trying to figure out every single problem this patient has. You want to focus on why they're in the hospital and get it done. And so we can start to even see this potential of completeness of the medical record as we move along. And so if you're a geek and you're interested in trying out some of these models, we've released our code. We've worked a lot with the community to make sure the data sets have some of the features that would be important for you. And I think that we need to work more on explanation, mitigation, and we are participating in a federated learning to improve the diversity of the labels that we have. This was done by a tremendous, amazing group of people across 3 continents, 6 universities, doctors, computer scientists, students, professors, and it's just been amazing, and encourage you to review how we do it using this village mentoring and hive learning experience. Thank you so much for the opportunity and great symposium.
Thank you very much, Dr. Gichoya. That was a really interesting talk.
It's on.
Can you hear me? Can you hear me now?
Should be. Yeah.
You can hear me? Okay. Are there any questions? I'll look in chat. Someone asked, where will this recording be posted? So we need to obtain permission from the speakers, and we'll determine that. Yeah, we can email all of the registered participants next week.
Awesome.
Okay, any questions for Dr. Gichoya? You're welcome to unmute yourselves right in chat, or we also have several participants here in the room.
Hi. So my question was regarding the methodology. So when trying to figure out what are the confounding variables that cause this kind of performance, I was just thinking, what if one used like saliency maps that allow one to understand where the model is actually looking, and then maybe compare those values with the confounding variables? Would that be like a good approach?
No. Saliency maps, we put them in because all the reviewers on your paper will not accept your paper without looking at them in imaging, but they are terrible. There's quite a lot of work that has shown that if you even just flip the labels, that the saliency maps, I mean, even if you change the order that you feed in your data or do the testing, we need better explanatory tools for medical imaging, unfortunately. That's a gap, but we still use them, and and sometimes they'll make sense, but overall they're not very useful. And we spend quite a bit of time on it, and other people have, but we don't know the why. And quite a lot of you have even been involved in debates like, does it matter if it works well for a certain minority population? And it doesn't, but you need to know that this is working because it's working, not because it's relying on a confounder. But I think saliency maps would be not how I think about it the first time.
Okay, yeah, thank you for answering that question. And I really enjoyed your talk.
Thank you.
Thank you.
Any other questions? Okay, well, I guess let's thank all of our speakers very much for all of your wonderful talks. It's a really great symposium, but it's not quite over yet. So before we move on, well, first of all, I want to remind everyone that following lunch at 1 o'clock EST, so in a little less than an hour, we'll be coming back here for a panel discussion on, what we can do moving forward and how data science can be incorporated more in racial health disparities research. So please join us again after lunch for this discussion. But right now, before lunch, we have some student awards to announce.